Yeah, thank you for introducing me and for the opportunity to talk today. So it was quite a challenge to kind of get everything in a 1 hour talk, but I will try to give a brief overview of the existing evidence of whole body MRI in oncology. And first, I'll tell you a little bit about the evolution of whole body MRI. In the end, it's not a really new technique. So the first paper dates back from 2004, and it was Takahara that actually created the sequence, which is a Japanese radiologist, and he used, or he coined it as a DWIPS, a diffusion weighted whole body imaging with background body signal suppression, so fat suppression, with free breathing and stir. And he quite quickly started collaborating with this other group, which is a group from Kwe and from Utrecht, and they in the Netherlands. And they've collaborated quite a bit in optimizing the technique and having the first experience in oncology. So they published this paper in 2008, almost 4 years later, showing the first examples of how we can show tumor in patients using this technique. But there needed to be some further optimizations because it's quite a complex technique. And also 15 years ago in MRI world is ancient history. So they needed to get a good homogeneity, to get nice equal fat suppression, get enough signal. So a lot of development in the coils was needed. And also to acquire that in a timely way. So free breathing is one way, parallel imaging was another way, but also using, for instance, a sliding table, which seems very normal and used, yeah, very normal to us, but actually it was quite new. So in this paper from 2000, that long ago, actually, they were quite excited to present this new table, which would slide. And instead of repositioning the patient, the radiographer would just come in after every station and replace the surface coil. So one on the top and one on the posterior end, which you can just kind of reposition, and to get these lovely images. Now, of course, this is completely changed. The moist coils are built in the table, and now we're able to get really nice and quick, well, relatively quick whole body imaging. So what was the first application? Actually, it was lymphoma, and it's quite clear why that was the first point of interest, because this is the PET image on your left, and this is the right image on the right is the whole body image. And it's almost a mirror image, but without the radiation exposure. And also when you look at these pictures, for instance, this is a fused T2 with an overlay of diffusion weighted imaging, and then a fused PET with CT and an overlay of PET CT. And again, that shows almost exactly the same amount of disease. So it looks like a duck, but does it really swim and quack like a duck? So before we proceed to the diagnostics and the treatment response assessments with the body diffusion, I just wanted to highlight this paper and the tumor environment of the B-cell lymphomas. So when we look at CT at lymphomas, they look very bland, we measure them, and that's about it. But actually, it's an extremely heterogeneous group of tumors with a completely different microcellular structure, with different prognosis, different treatment responses. For instance, in the Hodgkin lymphomas, the cellularity is quite low. In fact, you've got some sparse tumor cells on a background of inflammatory cells, and quite a big plethora, really, of inflammatory cells. This in contrast to an indolent non-Hodgkin lymphoma and an aggressive non-Hodgkin lymphoma, where the cellularity is much greater. Taking and then remembering that diffusion and whole body diffusion with imaging images cellularity, that has some repercussions in assessment. So this systematic route, or this meta-analysis, illustrates or summarizes all the papers that have been published on staging lymphoma using whole body MRI and comparing that with PET-CT. And they make a distinction between Hodgkin lymphomas and aggressive non-Hodgkin lymphomas versus indolent non-Hodgkin lymphomas. As you can see, most studies are quite small. In fact, the largest one is Meyerhofer et al., which published on 140 cases in general. And they looked at the staging of whole body MRI versus PET and showed that the whole body MRI is slightly inferior to PET. In contrast, looking at the indolent non-Hodgkin lymphomas, whole body MRI was significantly better than PET-CT. Now, why is that? In indolent non-Hodgkin lymphoma has variable FDG avidity in the first place. And secondly, for instance, small lymphomas tend to be in the stomach, and those are particularly difficult to pick up with PET-CT, for instance. So just highlighting this one paper from my group, because it's such an important paper in the field. It's a prospective study in 140 patients. And they actually saw, like I said, that in the whole body in aggressive is slightly less, performance is slightly less than PET-CT. And this is mainly due to staging of nodal disease. So the light gray bits or the boxes are the nodal disease, and the dark gray is the extranodal disease. And in fact, both for Hodgkin, diffuse large B-cell, which is a type, the most prevalent aggressive non-Hodgkin lymphoma, and in follicular lymphoma, the performance is slightly less for nodal disease. But the story is quite different for indolent lymphomas. This is an example for all the mild lymphomas. And in fact, if you look at this, the brightest is DWI, then PET-CT, and the darkest CT, it's clearly that the whole body MRI is more sensitive both for nodal, but particularly extranodal disease with similar specificity. After diagnostics, we can also look at treatment response assessments. And this is an example, for instance, of a DWI before therapy, shows this really big abdominal nodal mass. And after therapy, there's this little residual focus of restriction, which correlates with a low ADC. And looking at the PET-CT, it's almost, again, a similar image. It could be the same image almost. And this is reflected in the results as well. So the agreement between PET-CT and whole body MRI in Hodgkin, aggressive, and indolent lymphomas actually very good. And looking at the data as such, it appears that the discrepancy lies in the fact that PET-CT called complete response in 3 patients, while WLI, so diffusion called 3 patients a partial response. So it's again a very promising technique. There are some issues with treatment response in lymphoma, both for PET as for conventional imaging. So usually we image patients with PET, interim and end of treatment. Interim treatment would be particularly for aggressive non-Hodgkin lymphoma after 2 to 3 cycles. And then we're talking about, well, about 8 weeks or 2 months, which is quite a long time. And end of treatment is easily 5 to 6 months, which is really a long time before we can give a definitive answer whether this patient's actually doing well on treatment. Especially for aggressive non-Hodgkin lymphoma, an important addition to the treatment was the addition of immunotherapy. And that, of course, creates an influx of inflammatory cells. For PET-CT, can be a bit tricky for the interim PET to call false positives. So that was kind of the idea of why to perform this study. This was a paper by myself, published this year in Radiology and Imaging Cancer. And what we've done is we included 45 patients with aggressive non-Hodgkin lymphoma. We gave them a whole body and a PET at the baseline. And then we did a whole body CT, whole body MRI after 1 cycle. So 1 cycle is about 2 to 3 weeks. And then we looked at the response, and we looked at the response not by just looking at the images, but by calculating the ADC difference. And then we correlated that with the clinical outcome. So if there was still residual disease or recurrent disease, that would be a poor responder. And if it was a complete remission, that would be a good responder. So looking at this image, for instance, this is the baseline PET. The whole body MRI correlates really well. We've got this mediastinal mass, which is dark on ADC. And then after 1 cycle, we do the MRI and we see this focal hyperintensity, which is what we would delineate, not the entire mass. And that will correlate with the interim PET-CT here. And if we look at the histogram, not only do we see that the mass is a lot smaller, or at least the most hyperintense bit, but ADC is increasing. And that's exactly what we saw. So whole body was quite accurate in predicting the outcome of patients. It was actually more accurate than interim or end PET-CT. So actually was 87 versus 71 for interim and 74 for end of PET. And you can see that there were quite a few discordant patients, about 16. And only in 3 of the 16, whole body MRI was wrong. So in this case, we had a false negative, which turned out to do true positive on the interim, and then 2 false positives. Looking at the outcome and the Kaplan-Meier curves, the stratification between good and poor responders is better with whole body MRI versus interim and end of treatment PET. And in fact, whole body MRI was the only prognostic factor for outcome in the multivariate analysis. Right, so to kind of summarize for diagnostic and treatment response assessment performance, I think PET is excellent for Hodgkin lymphoma. I think it's better than whole body MRI, both for staging, but also for treatment response. For indolent lymphoma, it's a bit more nuanced in the fact that PET-CT, that whole body MRI is probably better than PET-CT in detecting disease. And in aggressive non-Hodgkin lymphoma, I think there might be a complementary place for both of them. I think they both have a really good diagnostic performance, and whole body might be a bit quicker and more accurate for an early treatment response than PET-CT. But we know the application of whole body MRI better in multiple myeloma. So multiple myeloma is or clonal plasma cells that are proliferating. And often it starts with MGUS, which is a benign entity. It's not malignant at that point. A subset of those will progress to a smoldering multiple myeloma, at this point still not truly malignant. And of that, about 10% of that proportion will then further progress into multiple myeloma. Now, the landscape has completely changed in multiple myeloma, where 10 years ago, your life expectancy was quite short. Actually, the 10-year survival is now 30%. And as you can see, it hits quite a young population, 15 to 40 years. And they have the best survival in these young patients. The myeloma survival, and this is really important, has quadrupled in the last 40 years. So where it was 6%, it's now 33% overall, which is quite amazing and does change things. So why is this? There's been extensive investigation, all these different cancer pathways, and this has led to the development of specific drugs targeting these pathways. So there are multiple treatment options now for these patients, which weren't there before. And that does change the diagnostics, because early days when there wasn't that much available, the defining events were end of organ damage, being that expressed by the CRAB lesions, so hypercalcemia, renal insufficiency, anemia, and bone lesions, and then predominantly osteolytic lesions. But these bone fractures, vertebral fractures, they really do reduce the quality of life, especially in patients that might live for 10 years. That becomes an issue. And that has kind of induced an additional criteria since the revised criteria, where they implement also MRI studies. So you need at least 2 focal lesions on an MRI study, and that might serve as a biomarker and make the definition of a multiple myeloma. And this is based on this study from the JCO, prognostic significance, where they looked at patients which were asymptomatic. And what they've done is they've done a whole body MRI, and they looked at survival. And they're trying to determine certain characteristics that might be helpful for predicting progression. And they found that a focal lesion, when there's more than one focal lesion, the survival is significantly poorer than in those that only have 1 lesion or less. And also in their multivariate analysis, it shows exactly the same. So it shows a really good significant result that once you've got more than one, that you have a poor outcome. They also found that diffuse bone marrow infiltration, which cannot be shown by any of the other imaging modalities, also correlates with a poorer outcome. And this has led to this consensus statement. So they base their recommendations on the available evidence. So A is the best evidence, D is little evidence. What is really evidence-based MRI is the gold standard method for detection of bone marrow involvement. Of course, it is a procedure of choice to evaluate painful lesions and spinal cord compression. It is able to accurately visualize soft tissue extension and extramedullary plasmacytoma, and it does provide prognostic information. It's not that clear if it can be used for treatment follow-up. We'll talk about that a bit later. And also, and when it comes to clinical management, it's not sure if you see more than one lesion in asymptomatic myeloma, if you really have to do, if you really have to start treating. And this is also reflected in the NICE guidelines, which at least everybody has heard of or know that they exist. So in suspected myeloma, the first line imaging is whole body MRI, if not available, whole body low dose CT. And skeletal survey actually, if possible, should be avoided because we know it's inferior to all the other imaging methods. In newly diagnosed myeloma, again, a whole body imaging method being MRI CT or PET CT. Looking at the diagnostic performance, there is one systemic review, which is a bit more critical actually, although despite of all the positive news about whole body MRI. And they've included about 6 papers. And as you can see, there's not that much data available. So we've got one study that compared CT to whole body MRI. Sensitivity is much higher for whole body MRI versus PET, and the specificity is quite the same. And if we look at the PET CT again, we see that sensitivity is a bit higher and that the specificity might be a bit variable. So in this study, it's 37 versus 62 for PET. Here it's 182, 83, 75. So that's a bit more variable, but it seems that whole body is more sensitive. But the issue is that these studies are really hard to compare because different protocols have been used. Also, the patients that got included into the study is quite diverse and not really comparable. So that makes it quite interesting and highlights that actually more evidence is needed to make a definite conclusion. Furthermore, not one study actually assessed the impact on management, which is also an important research question actually. Nevertheless, this is a study in blood, and blood is comparable to the radiology for radiologists. So this is a bit one of the best journals for hematologists, and they explained the difference between whole body CT, PET CT, and MRI, and when to use what. So indeed, whole body CT is patient-friendly, it's very fast, it's not very expensive, widely available. There is radiation dose, but it's not lower than PET CT, and you don't need to give IV contrast. But it does depict lytic bone lesions better. Well, it can't depict bone marrow as well as the other techniques. So if you want to look in, for instance, asymptomatic myeloma, or if you want to assess disease, you can see that in MRI, probably you're going to pick up a lot more disease because they have a much higher sensitivity for early bone damage. It has not a role, it doesn't really have a role in prognosis. And the favorite target according to the hematologist would be it's just for standard CT guided biopsy or for evaluation of fractures, while MRI is really the standard for detection of diffuse bone marrow involvement, which again is a negative prognostic factor, and to make a differentiation between osteoporotic and pathological fractures and assess core compression. But then moving away from diagnostics and really looking a bit further into treatment response assessment, the evidence available for PET CT is already quite abundant. There are a few large prospective and independent studies, but for functional MRI, these studies are still lacking. What we have now are independent series of patients, retrospective, quite heterogeneous in acquisition interpretation. And that's also reflected in all the evidence that's actually available. And I think the most important thing for hematologists would be the MRD. So MRD is a typical hematological concept, and it stands for minimal residual disease. And it means that a lot of these patients, and particularly in multiple myeloma, they get an induction treatment, and then they go to transplant, and then they go for a consolidation and then into maintenance therapy. So they get a lot of treatment, and what they want to see is when they've had their induction treatment, if there's still minimal residual disease left, that is an independent prognostic factor, negative prognostic factor. So how do you determine that. So now what they do now is they do a trephine, get a bone marrow aspirate, and then do a flow cytometry or do next generation sequencing, for instance. But often you do need a bone marrow sample, and that's where the trouble lies, because multiple myeloma is not always a diffuse disease. It can be very, very focal, as we said, it can be very patchy. So there is definitely a sampling issue when you have to collect bone marrow. So that's the idea of an imaging technique showing where, if there's still minimal residual disease, is therefore very interesting from a prognostic and treatment perspective. So these are the two major studies on PET-CT, and it's quite interesting. They have done quite an intense study. So they did whole body MRI. They compared whole body MRI without diffusion, I have to say, just whole body MRI, and compared it with PET. They did it at baseline after 3 cycles of chemo, so mid-chemo, and before maintenance therapy. And that last one would be the time point to pick up MRD. And actually, there is no statistical difference between whole body MRI or PET at baseline, nor for after 3 cycles of chemotherapy. But there is definitely a difference before maintenance treatments. So before maintenance treatment, there is, this is the PET, shows a better stratification in terms of survival outcome. But looking at it a bit deeper, so this was quite a big study with 134 patients, and they wanted to have a better look at that MRD. So they selected 68 patients where they had and the PET-CT and the flow cytometry. And what they found is actually not the flow cytometry or PET-CT independently could predict MRD or a negative outcome. It was more both of them. So if both the bone marrow and the PET-CT was negative, or they were both positive, that would lead to a very good prognosticating factor. And this is kind of reproduced in another really big study, which is even bigger than the first one. This is 240 patients in this study. And again, they show exactly the same, that you've got a better prediction of overall survival with PET between event, so progression-free survival and overall survival, that PET is able, negative PET has a better prognosis. And also illustrate this, and this makes it clear why PET does work and MRI doesn't work. So we've got the X-ray where you don't even see the lesion. Then we've got the MRI, which shows the lesion here. So this is the STIR MRI, and this is 160 days after treatment initiation. And you don't see a single difference in the MRI, which is to be expected because it's an osteolytic lesion. It takes time for fat to go back into the lesion. So, which is quite different from the PET-CT. So this is the baseline, and this decrease in metabolism is evident. And this is also what they saw, and this is a timeline. So this is the months from the start of treatment, and these are the different techniques. So actually, PET can show a complete response much quicker than, for instance, MRI or even a clinical complete response. So it seems that PET-CT is actually a really good technique there. However, there are encouraging studies with MRI as well, and that is mainly by using whole body diffusion-related imaging. So where they're going to calculate the ADC. And this is quite a good study, and I like the study because its methodology is quite well executed. They had a volunteers group and they had a disease group, and they checked for reproducibility between observers and within subjects as well. And they found actually that in the 25 patients that had treatment, that those that responded in general showed a higher ADC increase than those that were not responding. In fact, all 5 non-responders showed an ADC decrease. And this is also reflected in this histogram, where we find that this is the pre-treatment ADC, so it is quite low. And then moving post-treatment, the ADC is increased, and which shows that there's a favorable response. The main issue is, again, that there's not a lot of standardization. So a lot of work still needs to be done here This is a good start. This is published by Christina Messiu, who's quite active in the field, and she reported on the guidelines for acquisition, interpretation, and the reporting of whole body MRI in an attempt to get a more standardized approach and better studies. Now, moving forward to bone metastases, which is another quite well-known application of whole body MRI. For the sake of time, I'm mainly going to focus on prostate because it's a hot topic there. And similar to multiple myeloma, a lot of things have changed in prostate cancer. So a lot of people move from localized prostate cancer and they can be cured, or they go to an advanced prostate cancer, which might be hormone sensitive. And at a certain point, just due to tumor evolution, they will become castration resistant. Now, again, 5 years, 10 years ago, if you were in this group, things were exceptionally grim. There was not much out there to help you. But actually, in the last 5 years, especially with the development of abiraterone, the things have significantly improved, and patients spend quite a few years in this category. And detecting and evaluating metastatic disease is important. Why? Because we need to know when a drug is becoming, when they become resistant to a drug and when they need to shift or not. So having an accurate treatment response assessment is quite important in this group where there's not that many possibilities anymore. And furthermore, the tumor becomes more differentiates. So the PSA as a biomarker loses its valuability as well. So something needs to be done here to make that possible. So what are the guidelines now? So if you look, there's a low risk, intermediate risk, high risk, and locally advanced prostate cancer. So what do they advise? In the intermediate risk group, you can do cross-sectional abdominal pelvic imaging, whether that be CT or MRI, and a bone scan, bone scintigraphy. For the high risk group, again, bone scintigraphy, locally advanced, exactly the same. If we look at this table, what do we do in metastatic hormone sensitive prostate cancer? Again, when there's a PSA rise, a bone scan. In metastatic castration resistant prostate cancer, so when they're no longer responding to hormone sensitive treatment, they get a bone scan. So everything is a bone scan, and it does make you wonder why that is, because we know that a bone scan is actually not that good, that it's not a good technique to detect lesions. From a JCO study, even from 2007, actually showed that whole body MRI is much more sensitive than bone scans to detect disease. And it's not only whole body MRI, in fact. In this field, a lot of radiopharmaceuticals have been produced, which are really helpful in assessing disease. So choline, for instance, targets the cell membrane turnover and can visualize both soft tissue and bone disease, although it has limited sensitivity for liver mets. PSMA is a new star. It targets cell membrane protein expressed in prostate cancer, and its particularly high sensitivity makes it useful for detecting recurrent disease, because even in a low PSA or a low PSA doubling time, it's able to detect, for instance, nodal disease. What a bit more controversial is its role in tumor assessment or response assessment, particularly when they're still on anti-androgen therapy. This is correlated with an increase in PSMA, making it less reliable for this purpose. Then we've got sodium fluoride, which is also very sensitive to detect bone metastasis, but that's it. It can only detect bone mets. And then there's FDHT, which binds to the androgen receptor. Again, the issue here is that when your tumor becomes resistant to androgen deprivation therapy, that it's no longer sensitive. So what is the evidence? This is a quite recent review from December 2020. And it looks, for instance, here, how sensitive they look at the bone scan and compare it with choline, PET, and MRI. And this is over 18 studies, including about 2,000 subjects. And what they found is that the bone scan, yes, it really is less sensitive and has lower specificity than both choline or MRI. And then to detect in recurrent disease or detect mets, there are not that many studies, about 5 studies, and only a minority are really comparing MRI with PET. So we've got this study here, MRI and comparing choline PET. And that shows that sensitivity is higher for the local staging, lower for the nodes for MRI, and again, a better sensitivity to detect bone lesions for MRI. And there's this other study from Zakwa et al. That used MRI, PET, and sodium fluoride, and actually showed quite a low sensitivity for MRI. But there's a huge caveat in this study, which I do need to highlight, is that they didn't do a standard whole body MRI. What they've done is do a whole body MRI with a B value of 600, which is in fact a stir, if anything, and not a proper diffusion weighted image. The best study out there so far, I think, comparing PET with sodium fluoride and whole body MRI is this one, recently published in European Radiology. And what they have done is included about, 55 patients, and they compared that with the final diagnosis, this was their reference of standard, and they found that PSMA actually reflected the final diagnosis really well, and then whole body MRI actually showed a higher number of false positives and false negative results, 6 false positives and 4 false negatives, and was actually significantly worse than PSMA and sodium fluoride to detect bone mets. But I do need to say that this was, first of all, a very heterogeneous group. Anyone with bone mets could enter. And second of all, also the final diagnosis is a bit questionable because the final diagnosis was a panel diagnosis, whatever that might mean. So they reviewed clinical data and then did site-to-site evaluation of the tests, and if available, looked at follow-up, which is a bit vague because we tend to use the most sensitive technique as the reference of standard. But we actually do not know, because we do not have any histological proof, whether what is true positive of true negative, if it really is true positive of true negative, because we haven't biopsied. Right, so then moving on to treatment response. Again, for treatment response assessment, the bone scan plays a very prominent role. That does give some issues because not only is a bone scan less sensitive, as has been clearly shown, but also to see a difference, a response actually in a lesion is quite difficult. Nevertheless, the bone scan, like I said, is pivotal in almost any clinical trial, and they use the Prostate Cancer Working Group has developed these criteria, which are a bit confusing, I think. So the rule is a 2+2 rule. So if you've got 2 new lesions, which are within the flare window, the flare window is about 12 weeks from the start of the treatment. So that could be just a present lesion that has become visible. So then you rescan again. So after the flare window, and when it's persistent, when it's no, then you can call it stable disease. However, if there are any additional 2 lesions, so +2 again, then you would call it progressive disease. So it's a bit cumbersome. If you want to use this, I've always found it a nightmare to do RECIST in these patients, because you've got RECIST in the soft tissue, and then these 2+2 criteria in the bone lesions, and then you have to kind of mend it together. And it's quite tricky, and whether it's accurate, it's very questionable as well. This picture kind of illustrates the problem and how diffusion or whole body imaging can help. Because next to the bone scans, which are done on periodical times and several time points, PSA is usually followed up a bit more and serves as a biochemical biomarker. But this is not always perfect. So if we look at the first point, so the PSA is quite high. You've got a first MRI, and it shows extensive disease. Then they get treatment. They get abiraterone and prednisolone, and we do a second whole body MRI. At this point, the disease is much less, and that's reflected in a decrease of the PSA. Then we do a third whole body image because PSA is slightly increasing. And again, we've got these new lesions. They start on docetaxel, and there's a bit of a level here. It doesn't really increase much the PSA. But if you look at the MRI, in fact, there are many more lesions. It's frank progression even compared to the first whole body. And that's not reflected in the PSA, and probably that's because the tumor has dedifferentiated. So there's definitely a place for a more accurate or more sensitive technique. Unfortunately, a lot of that data, because if you go to lectures like Padani and Petralia, they can give you tons of examples of this, but in fact, the evidence and the studies are still lacking. Not much has been published. This is one publication from the Marsden group, published in PLOS-ONE, and they looked at total tumor volume and whole body MRI, and also at the ADC. They only did this in 11 patients. They did not only include prostate, but also breast metastatic cancer. And they found that when the total tumor volume, for instance, this patient, 180, increases to 690 is indicative of a bad responder. And also the ADC has decreased, which is also a bad sign, and shows that there's not a very good response. But in fact, big studies are lacking here. They show the volume of the treatment between responders and non-responders significantly different, and also the median. But I also wanted to mention, before I go to the next application, let's say, is that similar to myeloma, there are now a lot of initiatives to standardize whole body MRI in bone metastatic disease. And the MET-RADS, like the MI-RADS, has been published recently. I think rather than, even more so than in prostate cancer, it might have a role in breast cancer, because there you don't have all the radiopharmaceuticals that might be helpful, and you just rely on the bone scan and your CT, which we all know is not very helpful. In sclerotic lesions, we tend to call it stable, stable, stable till infinity, but we don't really know what's happening on the macrostructural level. And in fact, there's a recent study in radiology that shows that for breast cancer, there's definitely a role for whole body. That brings me to my last application. This is peritoneal metastases, and might be less well known than the other ones. So if you want to look at the extent of peritoneal metastases, we tend to use the peritoneal cancer index. What you do is just divide the abdomen in 9 different regions, and then you add upper jejunum, lower jejunum, upper ileum, lower ileum, so the bowel, the small bowel. And every single category can have a max score of 3. So your ultimate max score is not higher than 36. Now, why is this important, and how can whole body play a role in this? Well, the answer is in ovarian cancer and colorectal cancer. Ovarian cancer is a dreadful disease, because most people present with very advanced disease with a lot of peritoneal metastases. However, in contrast to other tumor types, those peritoneal metastases are quite different in the sense that they're less infiltrative compared to other tumor types, which makes them amenable to just strip off the peritoneum and get a complete resection. So you can do really extensive resections and get an R0 resection. What is of importance that we as radiologists can kind of indicate and help our surgeon show where the disease is, and also before surgery point out if there are any surgical critical sites which would preclude them from treatment. So critical sites are portal hepatis, retroperitoneal lymphadenopathy above the renal vein, and falciform ligament involvement, and of course small bowel involvement. So this study from Frontiers in Oncology shows this comparison between survival between primary debulking surgery and neoadjuvant chemotherapy. And it shows that actually patients that get primary debulking surgery do better than those with neoadjuvant chemotherapy. And they show another date where they show the difference between an R0 section, so when all the tumor has been removed, versus residual disease. And you see again, so the best outcome is for those with primary debulking surgery and no residual disease whatsoever. And then the second group is quite similar. So that's the one with primary debulking and residual disease, and those with neoadjuvant treatment, and then an R0 resection. But there's one group that does particularly bad, and that's the one with neoadjuvant treatment and residual disease. So again, it's quite important as a radiologist to point it out and to know what, and in that way influence the management of that patient. So it's particularly the group in Leuven that has extensive experience with this. So what they've done, this is a study that they've published in European Radiology already in 2014, and they compared whole body MRI, CT, and PET-CT for staging of patients with suspected ovarian cancer. So the MO was as follows: they would get whole body MRI, and they would also get a PET-CT as part of the workup. Now, in that institution, PET-CT is always a PET and then a high dose with contrast CT. So that was compared. Then they went to surgery, and the surgeons would follow the same template as a whole body template. So in the whole body template, you would describe all the different regions, and you would describe the type of disease that you see, if there's any disease, and then your surgeon would comment on that and says, yes, you're right, there's disease, there's no disease, etc. They would take it out, and you would have your histopathological correlation as well. And that showed actually a really good result for whole body MRI. So whole body MRI was more sensitive than CT and PET-CT, and that was predominantly due to a higher sensitivity to detect serosal disease, so to detect that small bowel involvement. And looking at just the two graphs above, that kind of illustrates that. So the darkest is the whole body MRI, lightest the CT and PET-CT. In fact, small bowel cirrhosis was not shown by PET-CT, was significantly better demonstrated on DWI. So small bowel mesentery, the same story, colon serosa and colon mesentery. And so that made quite the difference, which is logical because as we can see here, what we're talking about are really, really small deposits. So if you look at this patient here, so this is the PET-CT. It detected the lipid surface met here in the right iliac fossa disease, and there's some mesenteric disease here, which is also seen on CT. So we've got disease here, and then on the liver surface. However, if you look at the MRI, yes, it shows the liver surface disease. It shows again in the pericardial gutter disease. The extent of disease in the pelvis and the mesentery is much larger than was expected on CT. And in addition, you also see this gastrohepatic nodes as well. After that encouraging result, they've done a larger study where they compared preoperative assessment of patients between MRI and CT. And they particularly looked at things that would affect resection. So were there irresectable distant metastases? Was the duodenum involved, the stomach or the celiac trunk? Was the diffuse serosal carcinomatosis? Also the superior mesenteric artery and the mesenteric root are of importance. And are there any suprarenal retroperitoneal lymphadenopathies? And for every one of these categories, whole body really outperforms CT. So if you look at distant metastases, 79% versus 57%. If you look at diffuse carcinomatosis, 94 versus 56%. So it's clear that whole body MRI is actually better at detecting these. And indeed, sensitivity, but also specificity was higher for whole body MRI and was better in predicting an incomplete resection. This is again an example, and this also illustrates what we're actually looking at. So again, CT shows this mental disease, and then looking at, and then looking at the whole body MRI, we see this restriction here, and here, and here. So this is the mesentery lying over the jejunal and the iliac arteries, in effect. And we can also see this linear and nodular deposits there. And that was in fact confirmed during surgery that it was involved. That brings me to colorectal cancer. It might be a bit odd to talk about that because HIPAC is well known outside of the UK, but less applied inside of the UK. But I think it's going to be increasingly important because for a long time, Basingstoke was the only center, but there's a massive financial incentive as well. There's a lot of funding to start to set these high-back treatments. And that does require quite a very expertise team. You need somebody who's able to do the surgery and do the procedure. You need to be familiar with it. You need radiologists who are important to guide the treatment. But I think in the future, increasing amount of centers will be offering the service. So what is it exactly? So colorectal cancer, what they do in colorectal cancer is that they first do a cytoreductive surgery. So they remove as much disease as they can, and then they connect to this big machine. You've got an outflow and an inflow. So in the outflow, they inject drugs, being chemotherapy. That goes to the machine, it gets heated, and then it gets pumped back into the abdomen. So they do the surgery, and then they connect the machine, and for 2 hours, there's a continuous circulation of chemotherapy through the abdomen. And that has shown to improve survival. Can you do this in every patient? No, of course not. The PCI is really important. The extent of peritoneal metastasis is really important, and also the location. That's where we as radiologists really come in, and where we, using different modalities, maybe add something. Because, as shown by this paper, whole body diffusion MRI for the operability assessment in patients with colorectal cancer and peritoneal metastases, compared to CT, shows that CT only has a 43% sensitivity for peritoneal mets, compared to 98% for sensitivity of whole body MRI. And in fact, looking at the prediction of inoperability, CT had only 25% sensitivity, while whole body attained 91% sensitivity. So there is a big difference, and this is kind of an illustration what I'm really talking about. So if you just do a CT in this patient, for instance, this is not all the disease that has been depicted, but you can see some liver disease, some liver surface disease fat over here. And overall, the PCI was estimated as 7. Now, there's not a one precise cutoff in terms of PCI to do surgery or not, although there is a bit of a consensus that 12, 15 is probably around the max. Because again, these are very infiltrative. When they're affecting the mesentery, you just can't get them out. So limited disease essentially, limited disease essentially. Now in these patients, they've done a whole body MRI as well. And not what you see is that this restriction here is going all around the liver. So this is completely involved. And also there were additional signs of disease. So this was scored as a PCI of 19, which is substantially higher than a PCI of 7, and substantially higher than the PCI of 12. So during surgery, this was in fact confirmed that it was PCI 19. This is another example. This is a patient where on CT, we see here in the pericardial gutter, we see disease here, and this was estimated as a PCI 5. And on DWI, we see a lot more of disease. Again, here, some liver surface disease on top, under the diaphragm. A lot of these small deposits are probably positive, and they, on diffusion, it was a PCI of 26. And during surgery, a PCI of 33 was found. So it was very extensive disease. And the only thing I just want to mention before kind of concluding is this study here, which was done in the UK, at UCL by the group led by Stuart Taylor. And they looked at the diagnostic accuracy of whole body MRI as a first line thing in newly diagnosed colorectal cancer, and see if metastatic cancer and the pathway for detecting metastatic cancer was equal to the standard pathways. And what they found was that actually they had similar accuracy. They reduced the number of tests, the staging time. So the staging time is about 8 days for whole body, when they only did whole body MRI, and standard would be 13 days, and the cost was also lower. This is what they've shown here in their paper. So indeed, diagnostic accuracy, we look at whole body MRI staging, 67% for whole body MRI, standard staging pathway is 63%, there's no statistical difference. But looking a bit further, and also in the supplemental materials, it is quite important to know where these metastases are. So there's not a big difference to detect liver mets, but there is a difference in detecting lung mets. So the sensitivity of whole body MRI is actually 10% lower than that of PET-CT, or the standard staging pathways being at CT thorax. So that does raise the question whether we should add a normal CT thorax or not. But again, I do have to mention there is a huge difference. This was a multi-center study, meaning that 16 different centers were doing scans. And the quality between the scans was quite different. So it might be that in a center with really good whole body MRI, that we get closer to the 65% rather than the 55%. So what are the limitations? Mainly the limitations is in the studies, that most of the studies are single center studies. There's a lack of standardization in the sense that everybody uses different protocols, or heterogeneous study populations have been included. There is no pathological reference of standard. Often, especially in hematological disorders or extensive bone mets, you're not going to biopsy every single lesion, so we don't really know what's going on there for sure. And of course, there's the issue of availability and scanning time. In terms of availability, this graph is rather sobering. This is a graph showing the amount of MRI systems per million population in 2013 over different countries. And the UK is not really at the top of the class here. And although there are no recent numbers available, I don't think it has changed much since then. So like every new technique, in the beginning, there's a lot of excitement and everybody sees possibilities. And then as the evidence kind of builds up, there are also limitations. And that can bring the Statler and Wolford up in many people when, creating this comments like, oh, maybe it's just, is it worthwhile? It's not too expensive. Are we really making a difference? Does it really change clinical management? But I'm a true believer, and I feel that there are definitely really good, there are indications that are less suitable, but there are definitely indications that are really suitable. But what we really do need is to get more studies out and do more multicentric studies to prove that. And in that sense, we kind of run behind with PET-CT. And with that, I leave it for today. I'm happy to take any questions.